So today we're going to be discussing pediatric immunizations. The objectives for this lesson is to identify routine childhood immunizations and prevention of vaccine preventable illnesses, identify strategies to engage caregivers in discussions related to immunizations, identify barriers to immunizations of the pediatric population, and articulate strategies to address immunization hesitancy. Look at this face. So for those of you in pediatric clinics or those of you in family clinics who give shots to children, you're going to see this face. You're going to hear this question, why do I have to get a shot? You're going to hear it in the clinical setting. So why is that? Why do we have to give shots? What do you tell your patients? Childhood immunizations is a mainstay of preventable disease control. Immunizations reduce the burden of mortality and morbidity due to infectious diseases around the world. So vaccines are used to prevent diseases. The best example of this is COVID. In the last 2 years, hundreds of thousands of people have died of COVID infection. We have a vaccine now. This number has dramatically declined. So a lot of these vaccinated diseases are rarely seen anymore in the US. COVID, not necessarily. We still see it. We're probably still going to see it. But when you take diseases like polio and mumps and even chickenpox, there's a vaccine for all of these things now. Back in the day, everyone had chickenpox. Now that we have a vaccine for it, you rarely see it. Children don't get chickenpox anymore. Children really don't get polio or mumps. However, under-immunized children and adolescents are at risk for acquiring these diseases now because of global travelers. So travelers come over to the US, and in their countries where they're from, there's still an endemic. There may be an endemic of polio or an endemic of mumps. And so they'll come over here and they'll spread the germs, they'll spread these viruses, and our children who are under immunized or who do not have any immunizations at all, they're at risk for acquiring these diseases that we once eradicated. Vaccines are cost effective. So they're extremely cost effective. One vial can immunize several children. If all of these children get vaccinated, then the vaccine also, the disease also doesn't spread to the family. So in actuality, one vial can immunize several people. So you're going to have a reduction of hospital charges, and you're going to have a reduction of the need of staff you need to take care of these patients, which means you're going to have a reduction in the missed days of work or school. Not to mention, through the Vaccine for Children program, all primary care providers can get immunizations without a cost. And these immunizations are for people who qualify for Medicaid or for the uninsured. So it's extremely cost effective. As great as immunizations are and all of their life-saving capabilities, there are some barriers to getting children immunized. One is there is a shortage. One is a shortage or a product recall. So is there a shortage of vaccines in the area? Rural areas lack access to care. So is there even immunizations? Are there even immunizations in this area? Can people even get to these clinics to get immunized? Has a certain vaccine been recalled? And once it's recalled, can you get a replacement? Then you have the issue of parental vaccine refusal and media misinformation. So parental vaccine refusal. Immunizations require many visits. Sometimes they're staggered over time to achieve the adequate immunity that you want through infancy, through adolescence. So having to return every couple of months for several shots can be overwhelming to parents and the child. So that's when you might have some vaccine refusals there and the ability to get there. Media misinformation. Parents hear horrible things. They read horrible things on the internet and social media about vaccines, things that make them think that vaccines are not safe. So as the FMP, the changing and complex immunization schedule can be confusing. So you'll have to you have to deal with reimbursements and storage of the immunization, stocking issues. Is there a language barrier? Does your family understand what the patient is getting and why the patient is getting? Sometimes you have patients who have unique immunization needs because they are in a special population, so that there can be a complex immunization schedule. So all of these are barriers for vaccination. But the major barrier to pediatric immunization is going to be vaccine hesitancy. So to help parents who are vaccine hesitant, we want to listen to their questions and reasons for refusal or delay of vaccine. So you want to listen to them in a caring, non-judgmental way. Why is this family hesitant? Did they read something? Did someone tell them something? Uh, do they have a firsthand and negative experience with the vaccine? Is there information that they were given? Is it factual? You want to be familiar with the controversies and the misconceptions out there about vaccines, so you'll know um, where they heard it from, or you'll know if they can't explain it to you exactly why they're scared. You kind of know of the things that's going on out there that you're hearing about. Things about certain vaccines causing autism or developmental disorders. Maybe you hear things about vaccines causing central nervous system disorders, or that certain people shouldn't get a certain vaccine. So you want to be familiar with those misconceptions and those controversy topics about vaccines out there. Something else that you might hear are that infants and children's system, their immune system, will be overwhelmed by multiple vaccines. Well, you'll need to tell the family that a healthy infant's immune system is capable of fighting thousands of germs, 2,000 to 6,000 germs daily. And children will come in contact with this many germs just when outside playing on the playground or eating in a restaurant or even just walking around breathing. The number of antigens in an immunization are much, much less. So a child's immune system can totally handle vaccines, several vaccines actually at a time. Through this vaccine hesitancy, you want to make sure you emphasize the risk and the benefits of vaccines. You want to make sure you provide the vaccine information statement, and you want to make sure that you document your discussion about the refusal of vaccines, and that you flag this patient's records of unimmunized children or children who just flat out refuse to get immunized. So while much of the fear is caused by misconceptions and misinformation, some parents do have true concerns due to the possibilities of adverse reactions. So you want to inform them of the possible adverse reactions. MMR, varicella, influenza, hepatitis B, meningococcal here, these all can cause some form of anaphylaxis. Now, though these reactions are rare, they do exist, but there could be some anaphylaxis with these immunizations up here. The injection site could cause some syncope and could cause some swelling and bruising of the muscle it's given in. And then febrile seizures could result in children, for children 1 year febrile seizures could result in children who receive that MMR vaccine 1 year after they're given the vaccine. So you want to make parents aware of these adverse reactions. You want to provide them with the literature, give them the vaccine information sheet, and recommend other credible resources for them to do their own research, just so they feel comfortable. Immunization is a process by which the body is artificially introduced to antigens to help build a defense against that antigen, to provide future protection with the next exposure. So immunity is either attained by active or passive immunity. So active immunization, this is when you're going to have your live or attenuated viruses, your toxoids, and this is just introducing the antibody to the system, so the immune system can form a response. And then you have passive immunity, which are the immunoglobulins. This is derived from a serum of pooled human immunoglobulin. This is reserved for those patients who are immunocompromised or those who have problems making their own antibodies. So we're going to talk about the types of vaccines you will be giving in practice in the clinics that you're working in. So these vaccines are all recommended by the ACIP, which is the Advisory Committee on Immunization Practices. And this is a group of medical and public health experts that develop recommendations on how to use vaccines. So let's start with the active immunity in the inactive vaccines. So inactive vaccines, it's a killed antigen. It's not a live virus. Only the protein remnants that induce antibody responses. So common side effects are mild to moderate fever and local swelling and pain. And this is normally within the first 24 to 72 hours. And here's a list of the inactive vaccines that you give in the pediatric immunization schedule. DTaP immunizes against diphtheria, tetanus, and pertussis. So DTaP is what you give for children less than 7 years of age, and they get 5 doses of this at 2, 4, 6 months, and then they also get it at 15 through 18 months, and then they get it at 4 to 6 years. Tdap you give to children over 7 years old, and this is controlling pertussis. So pertussis is not a lifelong immunity. You don't get a lifelong immunity once you get your last shot between 4 to 6 years of age. So you'll require a booster. And young infants are at greatest risk for contacting pertussis. So our older children, our adolescents, and adults should get a booster to stop the spread of this to our infants. And then Tdap here also has tetanus prophylaxis in it. So tetanus prophylaxis is based on age, the nature of the wound, and the type of tetanus vaccine that you received prior. So tetanus, of course, is important to have. You want to make sure that you are properly immunized with it, because you'll have those instances where you step on a rusty nail, or you get a cut from a rusty fence or something. So this immunization will protect you from the tetanus toxoid. Polio is also an inactive vaccine, and it's given in 4 doses at 2 months, 4 months, 6 to 18 months, and 4 to 6 years. Polio is still around in other countries, and they actually use an oral polio vaccine. Here in America, we just use the inactivated polio vaccine. Other inactivated vaccines, you have the Hib, the H influenza. This is given in 4 doses. You have the hepatitis A vaccine that's given in 2 doses. And then you have the hepatitis B vaccine that's given in 3 doses. And here you can see the H influenza causes several of your upper respiratory infections. Hepatitis A is spread through oral fecal. The goal is to prevent the transmission to adults and also prevent it in other high-risk individuals, including international travel. Hep B here, we give our first dose at birth, and then of course, it's 3 doses total, but you also want to make sure that other groups of high-risk individuals get this hepatitis B. I mean, may need to get it additional after the 3 doses. HPV is another inactivated vaccine. It's given in 2 doses. It's given to males and females. It's contraindicated in pregnancy. CDC also recommends that the HPV vaccine is given to everyone through the age of 26 years of age. Now, people over the age of 26 may choose to get vaccinated, but for people in this age range, the vaccine provides less benefit because more than likely they've already been exposed to HPV. But for those from those people who are 9 to 26 years of age who have not been properly vaccinated, it's recommended for them. Then you have your meningococcal vaccine that's given in 2 doses starting at 11, and your pneumococcal vaccine. This is given at 4 doses. The thing about pneumococcal, there are several types. The pneumococcal 23 here is for children over 2 years of age who are in a high risk for getting pneumococcal disease. And those are children, immunocompromised children, those who have oncologic issues or hematology issues, or sometimes you're diabetics and things like that. If they are at any risk of your heart babies, cardio children, if they have anything that's affecting their immune system, then they should get the 23 valent of the pneumococcal injection. Live vaccines. So live vaccines are attenuated. It's an attenuated form of the virus. It does not produce the disease, but it usually brings longer and broader immunity. So some live vaccines are the MMR, and then the varicella, and then the rotavirus. So you have to be careful with giving live vaccines. You want to make sure that your patient is not immunocompromised. So no child, receiving chemotherapy or any issues like that, they should not get live vaccines. You can also not give it during IVIG therapy. So here we just talk a little bit about the MMR. It's 2 doses. All your live vaccines are going to start at 1 year of age. So you don't give the little babies the live vaccines. All live vaccines are going to start at 1 year of age, with the exception of rotavirus, and that's given at 2 and 4 months. So you have 2 doses of the MMR. And then the varicella, you have 2 doses as well. Remember, these can cause the localized pain, the swelling, and the rash. And then you have your varicella. And like I said, your rotavirus is contraindicated in patients who have a history of intussusception or SCID. Passive immunity. So passive immunity is providing pre-existing antibodies. It prevents or amends the disease. So it makes the disease less severe. If you come in contact with it, but you haven't developed symptoms, you get passive immunity to kind of help your immune system boost up so you can't develop symptoms of it. It's derived from pooled human immunoglobulin of animals or monoclonal antibodies. So this is going to be for those immunocompromised patients who can't receive those live vaccines, or for the under-immunized patient exposed to the disease. And these antibodies can be given IM or IV. Examples of those are going to be your respiratory syncytial virus, so for RSV, and then the coronavirus, the COVID-19 mRNA. So here, just discussing Synagis and the prophylaxis given to preemies because they are at such great risk for developing RSV. so they would get the passive immunity of that. Here is the CDC immunization schedule. And so use this schedule. Look up your immunizations on the CDC website. You can't go wrong if you follow the CDC's guidance. Vaccine schedules change. They change almost annually. So you as a FNP or you as a practitioner, you need to have an updated knowledge on immunizations across the healthcare setting. Like I said, you can find the most recent schedules on the CDC website, and it actually goes from birth all the way to 18 years of age. And then you have a schedule for those needing catch up. Let's say a patient has missed the immunization. Maybe they were traveling or out of the country, or parents were refusing vaccines and then they decide to come around and get vaccines. These patients are going to be using a catch up schedule. There's also a schedule for high risk patients, those for chronic healthcare conditions. Let's see. So here I actually have the immunization schedule from the CDC. This is birth to 15 months, and it just lists all of the immunizations here, and it gives when they're due. You can actually click on the vaccine and it gives you information and also a link to let you know if the patient is missing a dose and the patient needs to have a catch-up schedule, what to do if a patient has a chronic healthcare condition, what you need to do. So some great information. So visit the CDC website and just familiarize yourself with child and adolescent immunization schedule. It's a lifesaver. And we will discuss more of this in our actual live learning session. We'll discuss more of this in the live learning session. Here again is some common drugs that are combination vaccines. And we like to do combination vaccines just to decrease the number of sticks that a child has to have when they're getting immunization. So here we have a list here of some of the common ones we use in our pediatric patients. So the Advisory Committee on Pediatric Committee on Immunization Practices. This is the ACIP. So their guidelines. So doses must be given 4 days prior or later than a specific date. So if you have a patient that comes in and they're due for a shot 4 months later, you have 4 days prior or later than a specific date. You want to give live virus vaccines at least 28 days apart. You want to space injections 1 centimeter apart, 1 inch apart, and don't aspirate. Re-immunization is not harmful. So in case, a patient accidentally gets a second dose of a vaccine before time, usually not harmful. Reduced doses should not be given. You want to recognize and respond to adverse reactions. You want to make sure that vaccines are properly stored and transported correctly to make sure that they're still safe. There is an accelerated schedule for travel. So if you have a family that's leaving the country and they want to make sure that the patient gets all of the vaccines before they leave the country, they do have an accelerated schedule. Major contraindications is anaphylaxis. Anaphylaxis is extremely rare. Sometimes patients will get little rashes or things like that. And so the family wants to say, well, they're allergic to it. Last time they got, they're allergic to it. Rarely does anaphylaxis happen. Rarely is an allergy even related to immunizations. And if they are going to have some little form of allergic reaction, there's a risk versus benefit. And actually the benefit of being immunized against these awful diseases actually outweigh the the risk of an allergic reaction. Immunization, when you're talking about documenting, you just want to always make sure that you document your immunizations to prevent delays in vaccines or revaccination. And you just want to make sure that you provide the family with an immunization record after every immunization visit so they know what their child has received.